So you're very welcome to the MSc in Diabetes Care accredited by the University of Warwick. This is our overview, our programme information session. And so just to let you know that we will be, I suppose, the run through of the whole session and what we'll be doing today. First off, we will have Diarmuid Brannock, who's Director of our Academic Affairs, and he's going to talk to two of our existing students in Australia at the moment, participants on the programme, Dr. Jackie Brown and Dr. Sarah Lithgow. So we'll have a quick chat with them and see how they're getting on. And next we will have Dr. Colin Kenny, who's a programme lead for the programme. And he is going to give you an overview really of the state of the nation and in diabetes care and diabetes management in Australia, and I suppose just what's the most up-to-date information, and have a general chat, give you a sample of what it's like to, I suppose, integrate and interact with the University of Warwick programme. And then I will finish off with just an overview of the curriculum and the pricing and the experience of the learning management system. And then at the real end, for around 15 minutes, we will open to Q&A. Just to let you know, you cannot unmute yourself, you cannot share screen, and you cannot annotate. That's for security purpose, but also for ambient noise purposes. When we have a lot of people on the webinar, sometimes ambient noise makes it very distracting. So unfortunately, the only way you can interact with us is by chat, but you're very welcome to do so. You don't have to leave all your questions to the end. You're very welcome to add a chat question anytime you want, because we've plenty of our own staff on this webinar who can answer your questions. One other staff member, a piece of housekeeping, one of our staff members, Quiva, she will be reaching out to you if you have a name that's not an identifiable Zoom ID. So if you've like iPhone or Galaxy or something like that, she will reach out to you in private chat and just ask you for your name so we can check you in and make sure you get the correct follow-up information. So without further ado, I'm going to hand you over to Diarmuid, who's going to talk to our current participants on the programme.
Yeah, good evening, everyone. It's lovely to see you all on the call. As Rebecca said, I lead our academic affairs team here in iheed. So our role is working with the University of Warwick, working with the tutors, working with the PCDSA, the Primary Care Diabetes Society in Australia, and with the RACGP and accreditation. Kind of all things academic fall to us. Colin is going to speak more on the clinical diabetes side in a while, but what's incredibly valuable if you're thinking of taking on a program like this is to actually get a kind of warts and all perspective from people that are currently in the thick of it. So we're delighted to have Sarah and Jacqueline, who are two of our current students on the program. And I suppose, Sarah, I was just going to start with, what do you want to give just a little bit of background about yourself and kind of what drew you to the program?
Well, I'm a GP and I'm working in a community-controlled Aboriginal medical service, so an Indigenous health service, and we have an incredibly high rate of diabetes with very complex comorbidities. So I was actually really wanting to just improve my clinical care, but also maybe look at how we can actually improve our chronic disease care model. So obviously prevention would be nice. Yeah. So that's what drew me in.
How have you found the transition to online education? The vast majority of people in our programs, the average age in a program hovers kind of early 40s, and then there's obviously some extremes either side of that as well. But how have you found, so and the point I'm making is most people, it's been a while since they've done an academic qualification. How have you found kind of a return to study?
Oh, I know, it's great. I think the platform when you're using a laptop is very good. I haven't found it so helpful on a mobile. So I actually, probably like all of us, when you're professionally fully engaged, your life's very busy, and then sometimes it would be easier for me to do it some things on the move. I've actually really enjoyed the fact that it's made me read things that I might not have read.
Yeah.
So obviously for the average GP in Australia, we're going to read the RAC GP guidelines and the little handbook, but to drill it down and actually look at some of the papers in more detail, I probably wouldn't have done that without a bit of a push. And so I really enjoyed that. I must admit, I find referencing a real pain in the neck. And having to go back to that and thinking about it, and then it took me ages to work out how to use EndNote, and I totally relied on my son who's at university going, "Oh mum, I can help you here."
Brilliant.
Help me get my referencing sort of sorted out, because I actually hadn't done it for so long.
It's really funny. Rebecca will have a slide later that shows when we asked people who finished the program 3 years ago kind of what the key impacts of the program are. One of the things that they come out with is, you know, their ability to kind of critically appraise research kind of at primary source, and it is that discipline of going to source data, be it trials, be it journal articles, and taking your own view of it. I think irrespective of the field of diabetes, I think just that kind of refreshing that skill is something that tends to stand to a lot of people. Jacqueline, if I can turn to you, how have you found juggling the kind of part-time nature of the program? Because everyone in the program is going to be a busy clinician. People are going to have families, social lives. How have you found that experience?
Yeah, really good. So I signed up for this in one of these sessions last round, obviously, and I had my baby. I think my baby was about 6 weeks old when I enrolled.
Yeah.
And so I thought I would do something to keep my brain ticking while I was having a bit of maternity leave. And so I've returned to working part-time, and I'm doing some tutoring and studying, but I dedicate Thursday evenings to doing it before our tutorial on the Friday. So yeah, I've managed to fit it in, and I think like Sarah was saying, the really good thing about it is there's a lot of hand holding. You know, I was a bit nervous about returning to doing a university degree. You know, I'm the baby of the program, I'm sure, but I still felt a bit rusty about doing Harvard referencing and things. So I've found, yeah, the hesitations I had, I've been really well supported. And I think the way it's set up, it's very easy. You don't have to think, you just go into the module. All of the articles are there, all of the information's there. And I second what Sarah was saying about having a much more international focus. I think in Australia, it's very easy. I mean, we're an island country, but to be very insular. And I've enjoyed interacting with the students from Malaysia. We've got a WhatsApp group, and that's really nice. And reading, you know, the American guidelines and the UK guidelines, I think it's nice to have that international perspective. So, but yeah, workload wise, I've managed to fit it in. Yeah.
And have you found, and you know, admittedly you're only a couple of months in, have you found it's changing, either of you, how you're managing patients with diabetes?
Yeah, that today I was reflecting on what I would say tonight, and I think this is perfect for me. I've been a GP for 6 years, so I've had just enough time to accumulate those chronic patients that I think, oh, I've gone to the end of my knowledge now. I don't know what else to do. So I think this is a really perfect, pitched at the perfect level for me where I am in my career, because we've got access to really helpful tutors. We can ask clinical questions, so you can actually talk about your patients you're currently managing, and in the discussion groups you can bring up problems that you're having. So for me, it's perfect for where I am in my stage of my career. Yeah.
Brilliant. Sarah, how about you? Oh, I think you're muted there, Sarah. I think, yeah, I think the quote of 2020 is going to be "you're on mute."
Yeah, I suppose clinically it's helped a little bit. More about program organisation in that sense. Actually helped me because it's really given me a spur to actually, I was beginning to work on things anyway, but it's actually driven me with far more of a passion I mean, especially, I mean, that's what I was hoping to do, especially a lot of the reading around Indigenous health. I mean, you know, because I went on a little bit of a circuit with the first module and dived down into quite a bit of the evidence there, and just looking at what else has been done differently. That's inspired me that we can achieve so much more than we're actually doing. So I've been in battle with our management about our point of care testing HbA1c machine, and I think I've won at that point. So that's quite good.
I'm sure this is something that Colin is going to reference as well, but what we've seen over the years is the people coming off the program, you know, be they in Kuwait or Malaysia, acting as kind of advocates for change, for a better structure of care around diabetes. And that's our founding program director, Tony O'Sullivan. He was a huge proponent of, look, if we get a mass of people through programs like this, they will agitate and they will drive much better diabetes care in their countries. And, you know, surely that's one of the best outcomes you can have from a program. So yeah, I think that's hugely important. I'm conscious of time, and I'm conscious that we want to keep this to the hour if we can. So look, Jacqueline and Sarah, thank you so much. Pitch in at any stage during the conversation, but I'm going to hand over to Colin now to kind of walk through a piece about diabetes. So thanks, everyone. And as Rebecca said, if there's questions, the chat box down the bottom, if you just throw questions into chat, we'll answer them in real time as we're going through, and we'll kind of summarize all the main questions at the end as well. Cool. Over to you, Colin.
Yeah, Dermot, first of all, can you see my screen?
It's just coming up now. Yeah. Perfect.
Right. Well, good morning, everyone. Very nice meeting with you all. This is another variation on an Irish accent for you. There's not just one. And you can see that I'm the course leader. I'm really pleased to be the course leader. I've done it for about a year now. It's great fun. And as you know, it's the University of Warwick that we do the diabetes diploma through. And I myself have been a family doctor for 30 years. This is the journey we're going to go on this morning for about 15 minutes. I'm going to give you the course overview. We're going to look at the world of diabetes, some key course content, and then I'm going to give you a quick update on the management of diabetes this morning. You get great.
Rebecca, is that me or Colin?
No, that's Colin. Colin, we can't hear you at the moment.
Okay, we might just ask Colin to stop his video if he's having connectivity issues. Hang on a second. Colin's web connection is usually brilliant. Has he actually dropped off there, Rebecca, I think?
He has, yeah. Okay,
do you want to flick into the other piece and we'll come back to Colin's piece then?
Sure, no problem.
It's probably...
Sorry about that, guys. That's the joys of working from home all over the planet these days. What I'll do is actually I will go into the program overview, and Colin can speak at the end instead. Can you all see my screen?
Yep.
Perfect. Okay, so I'll just give you the curriculum overview and just kind of a detailed overview of the whole program and the learning management system. So first of all, I just wanted to give you a brief overview of iheed. You'll hear the words accredited by the University of Warwick and then iheed used in the same sentence. And who are we? Who is iheed, and how are we connected to the University of Warwick? So essentially, iheed is an online program management company, and we are specific in the medical vertical. So we don't do any programs outside medicine. We were formed by a GP, and we have a large amount of doctors and clinicians working on our staff and our subject matter experts. So we're an Irish company based in Dublin, but we have a large global footprint. We serve governments and healthcare ministries worldwide. We have a strong focus on primary care, but as our programs have grown around the globe, we have, I suppose, expanded the participants on our program from all aspects of the healthcare clinicians in terms of primary, tertiary, secondary, all endocrinologists, specialists, everybody has, every form of clinician has been working and participating on our programs, which we're very proud of. And then I suppose just to give you an overview, we have over 30,000 clinicians registered on the iheed learning management system and over 300,000 course completions. So if you haven't heard about us, we do have quite a large global footprint and large brands across the world. We do pride ourselves on very small groups though. So even though we take on around 300 students onto this diabetes MSc globally, you will only ever be in a small group of 25 to 30 people. So you will not know that there's other existing cohorts studying in tangent with yourself. You will have a really close relationship with the 25 to 30 students in your class. So the University of Warwick, they're top 10 in the United Kingdom. They are ranked 62nd in the world in the QS rankings. They have over 14,000 diabetes graduates, and they're a world-leading diabetes education centre, and they have had a CIDC, which is a certificate in diabetes education, for many, many years, which is hugely successful and popular in the United Kingdom. They're a member of the Russell Group, which is the leading research universities in the United Kingdom, and they have a strategic partnership, a very robust and long-standing partnership with Monash in Australia. And just, it's very important for me to just tell you that you will never see on your certificate the words blended or distance or online. You get the exact same qualification as those who study directly in the university. So that's very important to know. You're at no disadvantage and there's no difference whatsoever. So the postgraduate diploma I'll talk about first, and then the master's. So the postgraduate diploma itself is 12 months online postgraduate, and it, as I said, we have over 300 registrants per annum from all over the world. In Europe, it's predominantly UK and Ireland. We have a large participant base in the Middle East, the GCC, Malaysia, Japan, and Australia. We have also random and growing countries like Canada and the US and all over the globe. So it's really nice to see that mix being varied and more varied all the time. We have full international accreditation by Warwick, the University of Warwick. We delivered in Australia in partnership with the Primary Care Diabetes Society of Australia. We're very proud of that memorandum of understanding and our association with the PCDSA. We're currently undergoing recognition by the RACGP at present. So that's ongoing, but our students who are going through the program at the moment, they can also, in the interim, while we're getting the recognition, apply for self-assessment for the credits that you've studied on this program through the RACGP. We've designed and delivered by world-leading diabetes experts, and that's something that Jacqueline touched on. I suppose in many of our countries, you have a tendency to silo, particularly in a large country like Australia, into just thinking locally. And that's one wonderful thing about this program, is that you are educated by local experts, local clinicians in Australia, but then it's mixed with world-leading clinicians that are, I suppose, dedicated experts in diabetes management. But not only that, they're not just academics in universities. The beauty of the program is that they're all working clinicians at the cold face of diabetes management in the community. And I think that's really, really important. And it's delivered on the world's most advanced medical education platform. I know that sounds like such a conceited sentence, and it's a bit embarrassing sometimes to say it, but I've worked in university setting for over 20 years, and I have had the misfortune to see some very shoddy online programs where they're really just talking head videos and downloadable PDFs. So we pride ourselves in the fact that this has an awful lot of interactivity. It's very palatable, it's very engaging, and you move through very complex information in a very easy and palatable format. So I think that's just worth noting, that it's so far removed from that very isolated self-study. And as Jacqueline said as well, there's a lot of touch points and a lot of hand-holding and a lot of interactivity with the team. So you don't feel that you're studying in an isolated environment, and you do really feel part of a collegiate setting. So I think it's important to state that. So just to give you an example of some of our tutor network, Colin, as you see today, he's program director and he's RCGP examiner, and he's past chair of the PCDS in the United Kingdom. Dr. Mark Kennedy, he's the founder of the Primary Care Diabetes Society in Australia, and he's director of Choreo Diabetes Clinic in Melbourne. Katie Reid is a senior lecturer in the University of Manchester, and she's a world expert on clinical change in our behavioural change in a clinical setting. Dr. Martin Hadley-Brown is Cambridge University clinical professor. He's founded member of the PCDS in the United Kingdom and a member of the NICE Type 2 Guidelines Committee from 2008 to 10, and clinical advisor to the RCGP. And Ralph, I don't think he's with us today, he was in the last webinar. He's a GP in Melbourne and clinical associate professor of the University of Melbourne, and also on the committee of the PCDSA, the Primary Care Diabetes Society in Australia. So that's just an example. Of course, you have more tutors. So what does this program mean for me? As I said, we have small group sizes. It's usually 20, maximum 30 participants in one group. So you will never have exposure to a larger group, and you definitely are not a number with us in the University of Warwick. You are a name, and we get to know you very well. You particularly get to know Ian, who is one of our senior members of the academic affairs team. So you'll see him a lot on your tutorials, making sure you don't have any glitches. We have 6x6 week modules, and they're well paced, flexible structure. We break for holidays. And in between each 6 week module, we have a 2 week break. Well, it's not exactly a break because you have to submit your essay. But if you're working towards the module or throughout the module on your essay, hopefully it won't be a last minute attack on your 2 week interval. We have a personal commitment of 10 to 15 hours per week. Every time I say this in a real setting, I hear this gasp from clinicians going, I can't give 10 or 15 hours a week. Are you crazy? I have a full-time job and I have family commitments. Realistically, that is overstated. What's most important is to come to your tutorial once a week, the live Zoom session. It's not like today, it's not like us just talking at you. It's very discursive and it's very interactive, and that's the most important thing. And just engage if you can with the forum, and I suppose interact with the forum, and you'll have a topic every week. So 10 to 15 hours is excessive, but coming up to exams.
Yeah, I think that's what's on paper as what they call the notional learning hours that meet the education requirements. I mean, Sarah or Jacqueline, what's your take? How much actual effort and are you and you're both doing very well in the program, so what's your average week look like on the program?
They're both on mute. You have to mute them.
Oh, man.
I dedicate Thursday evenings, so I wait till the kids go to bed and I read the module. That probably takes me an hour, and then there's articles that are related to that. So if I'm being honest, I pick and choose those articles I want to read. So might read half of them, sort of thing, and then I do my discussion post, and then I come to the tutorial, and then with the assignment, I'm a crammer, so I tend to do it at the 2 week little gap we get before.
Many people are.
So I think if we averaged it out, and again, it depends what type of person you are. If you're committed to really, and you find a topic that's interesting, I think it could be up to 10 hours a week if you took it really seriously and did every task that was asked of you. What do you think, Sarah?
Unfortunately, I started off very well, and then my job got out of control, and have been putting out files a lot at work, so I've done a lot less recently. So again, I'm not supposed to be working on a Friday, so if I'm not actually working, then I was dedicating quite a lot of Friday, so a bit later than Jackie, and I actually enjoyed it when I was doing it because it's quite a break. So I definitely haven't got to the 10 hours yet.
I think that's
my exams.
No, I think most people are doing something along the lines of what Jackie was saying. They're putting an hour into the discussion forum, they're putting the hour into their tutorial, they're putting a couple of hours into reading, and then they will have a couple of late nights while they're doing an essay at not quite the 11th hour, but probably the 10th.
So I suppose to everybody that gives you a little bit of reassurance that notionally we're saying 10 to 15 hours, but realistically we understand that that's not really going to happen. And both Sarah and Jackie are doing very well on the programme, just to let you know. Yeah. So just to give you an overview of the actual modules and the module structure, we start off, the first module is core principles. So we look at epidemiology, diagnosis, screening, pre-diabetes classification, evidence-based medicine. Next, we go into the treatment. Once upon a time, it was the only thing that existed really was metformin and lifestyle changes. And now there's such a universe of orals and injectables, and there's so much to know in terms of stepwise intensification that it really is a new world. So the whole module 2 is dedicated to medicinal interventions, and also in extreme cases, weight loss surgery and pump therapy, and then diabetes in children. So that's quite an intensive module. And as I said, there's 6 weeks each, and there's a break in between of 2 weeks in between each module. And then the third module is self-management, and this is one that the clinicians have a tendency to really enjoy. This is all about behavioural change in a clinical setting and doing your motivational interviews with the patient. What we do in this circumstance is we ask you to take a video of a fake student or a fake patient or friend, and you do your motivational interview, and you upload it onto the system. And we have an ARC software where your peers in the group and your tutor can make comments on how you've done on your motivational interview, and there'll be a rubric of best practice for you to follow. So that type of interaction, I think, is really interesting in terms of competency-based assessment. And we just look at self-management as well. And in the United Kingdom, there is this phrase, no decision about me without me. So it's all about empowering the patient through knowledge and really getting them to take ownership of their own condition. And so finally, at the second semester of the diploma, we go into complications. So we go into microvascular first, and we also get you to conduct a video of a foot examination on a fake patient or friend, and you also upload that to the system in video format, which I think is another great example of online competency-based assessment. So that's, of course, we go into macrovascular after that, and a lot of time is spent on CVD and primary and secondary care prevention. And then finally, we finish in special situations. In the Gulf, for example, we spend a lot of time talking about Ramadan and Hajj, and obviously religious fasting can have quite a serious effect on hypo and hyperglycemia. We look at sports and diabetes, travel, mental health. Of course, you're 3 times more likely to have mental health challenges if you are a patient living with diabetes. So we really upskill you in all of these areas, and we look at older people, comorbidities and multimorbidities as well. If you're not sick of us and you can still you're eager for more learning, you can progress to the MSc at this stage. So we have 2 modules in the MSc. The first is essentially research methodologies, where you decide what your project is going to be for your master's, and you understand critical appraisal and research methods and quantitative analysis and qualitative analysis, but it's setting the groundwork and deciding what your research project will be. And then you do the professional project, and we're very excited and proud about this, that it's not just a word written thesis that will gather dust and sit on an academic shelf of a library somewhere unread by anybody but you and your supervisor. Our output from the MSc, we want you to have a conference poster presentation or a journal submission in a national or international journal, medical journal of repute. So the beauty of that is that you are giving back to the diabetes research community, and you hopefully will get published, and you will be able to add to your own biography and your own CV, really, in terms of being a published medic in diabetes research. So it's a win-win in those circumstances. So we're very proud of what we've achieved in the MSc, and our students are going through it right now. So how does it work? We'll start in Australia in November, and I apologise in advance because I know that's going into your summer. So, but that's the next intake in the region, because we're not just taking in Australia. We obviously there'll be students from Malaysia, as Jacqueline said, and there's students from Singapore, and the same time zones we group together all over the world. And so we commence then, so that's the orientation, and then we actually start the curriculum on the first week of December. So you have the weekly discussion forums, as I said, you have a topic that you cover and your learning outcomes that you have to cover for that week, and your tutor will throw out a topic in the discussion forum that relates to the learning outcomes that you have to cover for that week, and it will have links to reading, as Jacqueline said as well, that you would have to cover. And then you participate in the forum. Once again, it's discursive and it's guided and moderated by your tutor, and it culminates in the end of the week in the weekly online tutorial, which is in Zoom, just like this, but it's way more discursive and it's not didactic, and you get to interact and talk about. It's all about scenario-based learning and case-based learning. So you'll be talking about an individual with a HbA1c of X and a BP Y, etc. And you look at that individual, maybe they have complexities and comorbidities, and you just discuss that case in detail. And so in terms of continuous assessment, we have 2,000-word essay at the end of each module. And you'll be given that essay title very early in each module, so you get to ruminate and think about it before you start writing it. So hopefully it doesn't have to be last minute Red Bull all the time, but I understand where Jacqueline is coming from, because I would also be a last minute crammer. And at the end of each semester you have your exams. They're also online exams, so it's online proctoring, so you can sit them from the comfort of your own home. A lot of people would say, how would that have the same caliber or quality as a written exam in an exam hall? But be very assured that the University of Warwick, being world ranking university, it has a deep oversight into everything we do, and the online proctoring is extremely robust. You are actually supervised by a remote supervisor who watches you do the entire exam, gets you to pan your camera around the room, under your table, etc., and monitors while you do the exam, and also takes over your screen so nobody else can actually remotely access your computer. And so it is robust. So just the online experience, I did talk about that in some detail earlier, but as I said, it's very scenario based, it's very case based learning, it's a lot of visuals, a lot of interactivity, there's quizzes and hot topics to guide you along the process and just quiz you and get you to really understand in a palatable format each module and each section and learning outcome that you're looking at. So this is an example of a case study that we have in the Gulf group, and the HbA1c and the BP levels, and you talk about the individual in detail. And we have expert videos from key opinion leaders from all over the world, and we have the weekly online tutorials, as you can see there. So the program impact, we talked briefly about this previously, but you see there the purple is before the postgraduate diploma and the green is after the postgraduate diploma, and that's essentially confidence levels of the graduates doing our program. And just, I know we've talked a lot about doctors so far doing this program, but we have a wonderful mix, and we pride ourselves on interprofessional education, and we've huge amount of nurses, pharmacists, and all healthcare workers in the multidisciplinary team being upskilled together. And that's in our opinion, the absolute way that you, and best practice for education in any NCD management, because the individual living with diabetes, for example, will be interacting with a multidisciplinary team all the time. And I know that we said that, you know, a doctor might just have 2 to 3 hours of interactivity with a patient living with diabetes per annum. There's a lot of hours that they have to control their own condition by themselves, but with the pharmacist and RX renewals, they will have a lot more interactivity and a lot more engagement with other healthcare workers in the multidisciplinary cycle. So it's so important that everyone is upskilled together so the disease can be managed competently. So before is the purple and after is the green. So you can see confidence levels rose from the 40s up to the 100% in some cases in terms of prescribing CVD prevention in type 2 diabetes, initiation of GLP-1, or maybe recognizing emotional distress in an adult, a young adult with type 1, for example. So the impact is is very tangible. You'll see another impact slide here, and that's just asking a survey of the graduates in terms of where they saw the largest impact. And you can see the quality of patient care is very, very high. So it's a testament to, I suppose, the altruism and dedication of our students, that is something that it's one of their missions. And Sarah said it earlier, that it really is, when you have a high precedence of or incidence of type 2 in your community, it's about clinical outcomes and patient impact being the number one. And there's positive impact on careers, very much in some of the other jurisdictions that we were in the Gulf, for example, and the UK and Ireland. Some of the graduates of our programme are now in national steering committees in their country on diabetes, particularly type 2 management in the community. So they're actually guiding national strategy and influencing change at a national level. So that's something we're very, very proud of. You'll see their reputation and Sarah's favourite, understanding research papers and clinical trials. So administration and support, you will have your program leader like Colin here today. You have your tutor network, mentors and supervisors, like Ian, who's there somewhere, and your course management team, technical support and individual support. There is a lot, as Jacqueline said, there is a lot of touch points and a lot of hand holding and a lot of making sure that you don't feel isolated. Yeah. Sorry, Dermot,
no, I was just going to say, would it make sense actually to flip over to Colin now and come back to the entry requirements and fees and that sort of stuff at the very end?
Sure, no problem, no problem. Yeah. We can end that for a second.
Cool. And
folks, I apologize. I've got to get to know my neighbors quite well in lockdown here, and we all complain about our internet, and I think there's too many people on the internet here. But Dermot has got my presentation, and he's going to share this with you now. That's where I started off. Next slide, Dermot. And yes, we were going to go on a journey, but I apologize, my Wi-Fi went on another journey. And that's what I said I would talk to you today about. Next slide, Dermot. And I talked about Australian coffee, and Dermot, next
no, we didn't get any of that, Colin. You'd broken at that stage from us. So I think you could probably go from here.
There we are. So that's, again, Rebecca's covered this a little bit, but I think it's important to say that the course didn't arrive from nowhere. It matches on to the International Diabetes Federation curriculum. We do cover type 1, but particularly type 2. All our tutors are experienced in diabetes care. We tend to focus what's important in your region. I like to think our management's up to date. We do talk a lot about individualizing care, as Rebecca said, and we do give important updates, studies and guidance. It is an online format. It's flexible to where you work. You can participate from your office or place of choice. There are weekly tutorials which were recorded and are available for you to look at. And we do think there's quite a bit of interaction and motivation. Next slide, please, Dermot.
Yeah.
So I want to talk a little bit about the world of diabetes. Next slide, Dermot. I'm going to start by talking about the pandemics. This particular, on the left side there, diabetes and its driver, the largest epidemic in human history, was quite a striking headline when I saw it a couple of years ago. It just reminds us that it is quite a big problem, diabetes worldwide. But then another pandemic came along in the shape of diabetes, and later on I will explain to you how the two have been quite closely related. Right, global inactivity. I must say in Australia you are not too bad in terms of global inactivity. Just look at Kuwait there, which is 67% of the population are completely inactive. Just in case you think I'm crowing, about 46% of the population in Northern Ireland are inactive. But it is a big driver for diabetes. Next slide, Dermot. And there you are worldwide. Not only is the prevalence quite high, but that prevalence is increasing at quite a dramatic rate. So 2030 is not that far away, and the IDF are predicting 438 million people living with diabetes at that time. Australia hasn't escaped that. As you can see there, you have 1 million Australians living with type 2 and 2 million with pre-diabetes or who are at risk, high risk of diabetes. And Sarah touched on that briefly. Next slide. And you your Indigenous population is particularly affected. Next wee bit, Dermot. Your Indigenous population particularly affected. When I worked in New Zealand, I was struck by how affected the Maori population were there with diabetes. And here you are in Australia, your Aboriginal and Torres Strait Islander population have 4 times the incidence of diabetes than the ordinary population. Module 1, we talk about diagnosis. As you know, it's a line in the sand. Next wee bit, Dermot. And that line in the sand, you will have discovered, Jacqueline and Sarah, is, next wee bit, Dermot. Yeah. Maybe you're going to tell me it is, next bit, Dermot.
Yeah, I've got the, are you not seeing the
48 or 6 point?
I think there might be a slight lag.
A slight lag on me here, yes, 6.5. I'm going to explain to you why that is, why that line in the sand has been drawn, but essentially it's to do with retinopathy starting. Next slide, Dermot. And then in module 2, we get into management of diabetes. There are a lot of guidelines worldwide. Because we are an international diploma, we start with the ADA guidance, mainly because they bring them up to date every year. So that's the 2020, there'll be a 2021 commitment as well. Our NICE guidance in the UK has got a little bit behind, and here in yourselves in Australia, you produced new guidance in July this year. And of course, one of the interesting things is to compare and contrast the guidance worldwide. I haven't had a chance to really look at your Australian guidance in detail, but it matches fairly closely onto the ADA guidance. As I say, SIGN is just revising their guidance. NICE is revising their guidance at the minute. Next slide, please. And well, there's the medication. Oral medication, most people start with metformin, and then it's what you use at the next intensification is the interesting discussion. And you've got some very traditional agents and then some newer agents. And of course, we do deal with injectables, the insulins and the GLP-1s, which I know you get access to in Australia, but are extraordinarily expensive in the Middle East. Insulin is a very interesting subject. Insulin does what it says on the tin. You do get a good response to insulin, particularly if you're type 2. Of course, for type 1, you have to live. You need it to live. But there's no doubt there is objections in the general population to injectable therapy, and that's well illustrated in this little cartoon. And we tell you ways of getting around that. Next slide. We also let you know where the drugs all work, and you would expect any course to do that. They are widely distributed in the body and they work in different ways. I'm not going to go into this morning, but as you might imagine, this is an important part of the course. Next slide. Well, targets are a very interesting subject. You can see even within the American setting, there's various targets drawn. But the important point, next part, Dermot, the important point is that not so much the targets as such, but that you have an informed discussion with the patient about what target to take. Next week, yeah. So it's based on individual characteristics, preference, potential side effects, and costs. So it's not just bland targets. And how you might help your patient set as a target is to start at the problem, develop a collaborative goal, and validate their goal and plan. Next bit, Dermot. Because the mantra is that there should be no decision about me without me. That should really inform your patient choice. We do this in great detail in module 3 because there is a need for an expert patient, because the person living with diabetes may see you as a healthcare professional for about 3 hours a year, but they themselves have to live with the condition the other 8,757 hours. And therefore part of your duty, and what we explain to you in module 3, is to empower your patients to look after themselves. Next slide, Dermot. And then language does matter. If I'd been talking to you 10 or 15 years ago, I'd have been talking about diabetics. That's no longer an acceptable term. They are people living with diabetes, and they need to be approached in a non-judgmental, assuring, stigma-free way. And that is very important to us as well. We do teach you about emergencies. Many people worry about mixing hypo and hyperglycemia. They are quite clear cut, and we'll explain to you very carefully how to distinguish between the two. Next slide.
We have a question in there from Chris Hogan about the role of the patient's informal carer. Would you be able to talk about that just in terms of where you were in the last slide?
Well, I wonder what you mean by that, about formal care. Is that the type of structured care they get?
Informal carer. So let's say their partner maybe, or their family.
Or actually, the point that's been raised on previous calls that we've had is, you know, they will see others other than their physician throughout the year. So, you know, that wider multidisciplinary team around the patient. So, you know, in this case, the podiatrist, their pharmacist can be a first query point for many things. I think so. You know, outside of the pure kind of doctor's clinical setting, I think might be the query.
Yeah, and I think it's also very relevant because dealing with the Maori population, as I did, they often get other medicines. And I'm sure if you're looking after an Indigenous population, you're aware of this, that they have their own medicines and approach. And I think it's important that that's understood and is shared with the clinician. But also I feel that, you know, I think people get a lot of informal care. Some of it's quite good. Others can be detrimental, and I think part of a shared discussion with the patient is to understand where they're coming from. And here's a patient presenting just now. Next slide, Dermot. They're 67, they've had diabetes for 15 years. They come into the treatment room and the nurse calls you down to see this. So I just sort of wonder, would this be a cause of concern for anybody? Anybody like to maybe talk to me about this foot? Would it be a worry?
Have to be a chat now, Colin, as opposed to
right. Okay. What I would say, this looks because I've been dealing with emergencies, this looks straightforward enough, but I would actually be very concerned about this foot. I can see that it's red. There's infection tracking from it. I suspect there's a deeply infected ulcer here, with a suspicion or worry about osteomyelitis. So in fact, although I've talked about hypo and hyperglycemia, I would say that this is also an emergency. And this patient needs to needs to get intensive hospital treatment, same day as an emergency. So next slide, Dermot. Okay, and this has been touched on already, but we do in module 4 do microvascular, and in Dermot, next slide, in module 5 we do macrovascular complications, and you know there is a full module devoted to each of them. One of the things we talk quite a bit about is microalbuminuria and albuminuria. Next slide. Because it's very important to get an accurate albuminuria, because as you can see from this schema, you can go from, even if you have an eGFR of say 50, you can go from being at moderate high risk of chronic kidney disease to very high risk of chronic kidney disease if you have albuminuria. And those of you looking after Indigenous patients will know that it is peculiar to Indigenous populations that they do run a very high risk of early renal failure. So next slide, Dermot. Yeah, so we're on to breaking trials and updates just now. I'm continuing on this journey. I just wanted to give you a quick update on diabetes. Next slide. This year has been really dominated by COVID and diabetes. It's just worth observing that overall mortality in a diabetic population was 28% if you had COVID. That's very frightening. This was admittedly initially Chinese data. Older age, early evidence of organ failure, high C-reactive protein on admission and low oxygen saturation on admission were predictors of mortality in diabetic people with COVID. And then there's nearly a linear relationship with a high BMI and mortality. Next slide. We then got some UK-based data. The striking thing about it was insulin users did worse. The high frequency of diabetic patients having it, but also in the UK population, we saw a disproportionately affected Black ethnic minority population. And again, once again, in the UK population, we saw obesity as a very big risk factor for mortality in COVID. Next slide. Just wanted to kind of quickly update you because this has emerged in the last month. Is a new indication for SGLT2s and heart failure. Two big studies, DAPA-HF and EMPEROR reduced. Both have shown benefit in heart failure, and it strikes us that SGLT2s will now get a license for the treatment of heart failure. Because remember, if you don't have diabetes, then SGLT2s have no effect on your blood sugar other than giving you a bit of a diuresis. Next slide. Just wanted to talk to you about the DIRECT study, very interesting study. As you know, if you get a soup and shake diet of 800 calories and you lose up more than 10 kilos of weight loss, then you can, 64% of the population of people living with diabetes will go into remission. And that's quite striking, Dermot. And next slide. That has led, I don't read the Daily Mail, by the way, but that has led to this headline in the Daily Mail that yes, they're going to a much bigger trial now in the north of England where a soup and shake diet, which sounds terrible, is going to reverse diabetes. So I think that's a very interesting development. Next slide. So next slide, Dermot. Yeah. So there we are. That is the cardiovascular outcome studies. Now, this is complex, but of course we'll deal on this with you. A lot of these have now reported, Dermot. If you whiz through it, you'll see that the ticks are the ones that have now reported. I've already mentioned EMPEROR, but this has been a very important development in the diabetes world. Next slide. Because in turn, it has informed guidance. And that's very important. And guidance has changed in the last couple of years. There, first of all, is a forest plot of all the important cardiovascular outcomes. You can see they're all to the left, some more striking than others. And we will be going through those all with you when you do the course. But it has really informed what we do. Next slide. In 18, we got very important guidance from the ADA EASD, and then Dermot, next bit, we got that updated then in 2019, and now the consensus is, next slide, that essentially metformin is your first drug of choice, but if you do have either high risk of atherosclerotic cardiovascular disease or kidney disease, then you probably need to get one of the newer agents, SGLT2s or GLP-1s. Next slide. And the current consensus is if it's atherosclerotic cardiovascular disease, GLP-1 is the one of choice. If it's CKD or heart failure, then an SGLT2 is your drug of choice in that setting. Next slide, Dermot. And that has led us to a overall algorithm. Looks complicated. Again, we talk you through this algorithm, but if you've already got very high risk or existing complications, you probably need one of the newer agents. If you're at risk of hypoglycemia, that's your choice. If weight loss is an issue, that's your choice. And then finally, if cost's an issue, you're down to TZDs or SUs. Next slide. So that's a quick whiz through things. I've told you about the course and what we cover. I've told you about the world of diabetes. It's a big issue. I've talked to you about what the module holds for you, and I've talked about modern management. So there we are. Why should you do it? The challenge is that we're all delivering diabetes care in a rapidly changing environment. If you do deliver diabetes care, you have a responsibility to stay up to date, of course. So we offer you that solution then at the University of Warwick in the terms of a comprehensive, convenient way to get your knowledge and skills up to date. We ensure that materials are relevant and up to date. We work with you to develop your knowledge and skills. It's just not a one-sided program, as Rebecca has said. And we have very good support in terms of technology, learning and motivation, provided the Wi-Fi stays up. Thank you, Dermot. Next slide. So guys, I've been sitting too long. As you know, sitting is the new smoking. Last slide, and I'm happy to take some questions. I already fielded a question from Chris there. Chris, I hope I helped you there. Any further questions at this stage?
I'll just give the last few slides because that might answer a lot of questions.
Sorry, Rebecca. Yes, I did cut across you. People will be asking that.
Yeah, exactly, in terms of fees and entry recs. So I'll just do that quickly because I'm sure that will answer a lot of questions for everybody. So you can see that, yeah?
Yeah, brilliant.
Great. So what you're asked for when you are applying for the program, as I said in chat, it is for clinical bachelor holders, so nurses, doctors, pharmacists, healthcare workers holding a clinical background and a bachelor in clinical medicine. We look for your degree transcript, and we look for a personal statement of 500 words. That's essentially just why you want to do the program and just your motivation for participating on the program. We look for an employer or academic reference. That's not to allow you to do the program, but more or less an overview of your personal standing as a healthcare worker. And then a photo ID, not a selfie, but a legal photo ID like a driving license or a passport would be perfect. And even though this is an online program, and as I said, we take multiple students from all over the globe, we do limit the places. We do that very much intentionally because we are adamant that we want to give a lot of individual care to our participants on our programs. So we never go over the 30 mark in any cohort. And so as a result of that, we do have limited places in each time zone of the world. And they are filling very, very fast in Australia, Malaysia, Singapore time zone. So if you are interested, I would urge you to begin the process of application. And we will be sending you out an email after this event. So the fees, the most important slide of the whole lot. And just to let you know, we do charge in euro. And so what I'm giving you in Australian dollars today is indicative only. Based on world and global events recently, currency fluctuations can be quite profound. So what I quote you in Australian dollars today may not be the same tomorrow. So we always charge in euro, and this is just indicative. So I just want to be very clear on that. So it's 7,500 euro for the program. And we have an early registration discount, which will be up on the 16th of September. So that's the deadline for that. And it's significant. You get 700 euro off the price, the equivalent of 1,150 Australian dollars. And so the cost to you, and this is for the postgraduate diploma, would be 6,800 euro, which would be equivalent to around 11,050 Australian dollars. That is for the diploma. If you want to go on to the Master of Science thereafter, you're very welcome to do so, and that would be, depending on the day, between 7,500 and 8,000 Australian dollars. But 4,500 euro is what you will be charged. So to secure your place and make sure you get in for the next intake, your place is not secure until we receive your deposit. And the deposit is 1,000 euro, which is approximately 1,750 Australian dollars. And then you can pay either by month or by semester in 2 installments, whichever you prefer. Most people pay monthly, but it's entirely up to the individual. And so the student experience, 300 students plus from 25 countries, actually that's 36 now, 88% student engagement. I think that's extremely high for an online or distance learning program. And we can tell that from the analytics on the back end of the system. So in terms of page views, interaction, tutorial, attendance. So participation is very high.
It's also, I think, Rebecca, I think it's really important that that figure isn't 100% or coming close to it, because it's recognizing that, you know, people will have peaks and troughs and busy times, and, you know, that the program has that kind of flex built into it, that, you know, the expectation isn't that you need to do absolutely everything to pass your exams or your essays.
Exactly. And the tutorials, if you do miss them, guys, just to let you know, they are fully recorded. And so you can, for whatever reason, if you miss it, you can watch it afterwards. Obviously, we would have a preference for live attendance, but it's not the end of the world. As Dermot said, if you can't attend, you can make up the time, no problem. And 92% pass rate, that is not a reflection of easy marking on our part. It is a reflection of the dedication of our participants on the program. And just, I suppose, they put in their own money, time, and they are mature working individuals in a clinical setting, so they work very hard on the program, and it's a testament to them that the pass rate is so high. And so the summary, so it's 12 months for the PG dip, it's an additional 8 to 10 months for the masters, so it's 20 to 22 months for the masters if you want to do the whole program, but 12 months for part-time learning for the PG dip. The next intake commences at the end of November, so you still have time to think about it. The award is from a top 10 UK university and 62nd in the world in the QS rankings. It's entirely part-time, and the convenience is you can access it anytime, anywhere. So you can build your study around your own life and your own commitments. And it is very innovative, it's very engaging, and you will get a lot of support from the team. What I will say is we will be sending you out an email after this with the recording of this event, with an apply now link and a pay a deposit link to secure your place. On top of that, you will also be reached out to by a member of our education advisor team. They will call you on your phone and ask if you have any other questions, if you want to proceed to application, and if you want to just chat a little bit more with them, you're very welcome to do so. So you will get that follow-up email within the next 24 hours. So I will just stop there, and you're very welcome. We invite you to add any additional chats into us. They're coming through thick and fast now, and we can read them out.
Yeah, so Holy basically has a concern of, look, she's on the road often between communities and might not be able to make tutorials. I think what's really important is there's only that 1 hour a week that you need to be available online at a specific point in time to do the tutorial live. The discussion forums, all of the kind of the online material you'll go through yourself, the readings, all of that you can do completely at your own pace during the week whenever suits. It's that 1 hour slot, and we'll agree that with each group as to what makes sense for the majority of the group. That's the only time. They are recorded now, obviously, because they're back and forth, and you know there's a lot of interaction. It is better to attend them live. There's absolutely no doubt, and you know the vast majority of people do. But if you miss one, you can catch it up. It's online within a couple of hours of it happening. So yeah, it's, you know, there's lots of people I think that are in a similar position where they work remotely or they're on shift patterns that change. That, you know, it's part and parcel of it. do we group participants from the same country based on time zone difference? It will be done pretty broadly by time zone. Yes is the answer. And what we'll do is we'll look at kind of what makes the most sensible group composition. So for the group that Jackie and Sarah are in, they're in it's a bunch from Australia and a bunch from Malaysia. The year before that, we actually had a group of Japanese in as well. So we'll make that make sense. But I think what's really, really valuable is the perspective of kind of looking at what a structure of care and scope of practice is like in other countries dealing with diabetes. So that kind of international mix it makes for a really interesting debate. So let me see what else has come in. The course fees,
Yeah.
we'll email them out. I don't want to, unless you have them to hand there again, Rebecca.
Yeah, it's 11,000 approximate Australian dollars with the early registration for the postgraduate diploma, and it's additional 7.5 approximate Australian dollars for the MSc if you want to progress to the MSc after the PG dip. But we always charge in euro because obviously it could be exposed to currency fluctuations. But it's 11 and 7.5 as it stands today.
Yeah. The question on tutorial timings there's a logic to kind of when the tutorials take place, but the discussion forum post, so a case vignette will go live at the start of each week. And then, so if you imagine, you look at that discussion post, you contribute to it at some point during the week, you're going through the online content yourself during the week. And then towards the end of the week is when you come together with your group and your tutor, and you've a very kind of patient case-based discussion on the content. So that makes sense to happen towards the latter part of the week. Evenings tend to work best for our other Australian participants. As Colin has noted, the students in the Middle East, they prefer lunchtime at the weekend, but if I was to place a bet now, I'd say it would be evenings. Thursday, Friday is what is likely to suit best. And
Anne did ask if
Jackie's done the entire of the course during the evening.
Anne has asked, can a personal care worker do the program? And you must have a bachelor in a clinical background, so you must be a nurse or a doctor or a pharmacist or a dietitian with a dietetic degree. So you have to be part of the clinical multidisciplinary team that interacts with a patient living with diabetes.
Yeah, so the formal University of Warwick requirement is a health science degree. That's the when you kind of boil it all down, that's what they'll look for. Is there anything we haven't touched on at this stage that people want to ask on chat? Or Sarah or Jackie, is there anything from your participant perspective that we haven't touched on that you think we should?
Well, Dermot, I think learning should be fun, and I've actually think it's great fun. It's all seemed rather serious this morning, but my students have all universally enjoyed it. I think Sarah sort of touched on it by saying that it's the meeting other students from around the world, hearing what they have to say, listening to what their clinical experience is actually a very enjoyable component, both for the tutors like myself, but also for the students as well. And of course, you go on a very steep learning curve, as I have. I've learned a lot about Middle Eastern culture, and I think it's been very interesting. So, and I think the other bit is that you do bring up skills again of writing, word processing, all those skills get sharpened up again, and I think that's a great asset to you.
Yeah, absolutely. And I think, Colin, I'd emphasize that bit of fun and informal approach. I think, you know, the university will take the admissions criteria very seriously, and they'll take the assessments very seriously. I think it's very fair to say the delivery is done in a really informal manner. We get to know everyone really well. There's a great rapport between the tutors, the program managers like Ian and the people on the program. So yeah, I think that bit can't be overstated. It's a very approachable bunch of people that are running the program. Just looking.
Sorry, dear, but our students do set up their own WhatsApp groups and chat away to each other and get to know each other very well, and come on the Zoom sessions a little bit early sometimes, chat not only about coursework but also about their own holidays and their own challenges during our crazy new world. So there is a wonderful bit of fun and collegiate experience as well.
It's funny, I'm on the WhatsApp group for the group that are currently going through doing their MSc projects at the moment, and it's probably the most active one on my phone. So just looking at Holly's question there, is it strictly 12 months or can it be stretched? It goes by semester, so you could do a semester and then take a break and come back to that semester 6 months later. To be honest, I think the pace of the program is probably about right. You know, what we looked long and hard at different delivery models but before coming up with this, and having a reasonably intense period where you dedicate a period of time to study, and like Jackie says, you know, where you kind of hive off a part of your week and say, right, Thursday evenings, that's when I'm going into that room and I'm going to study, and the rest of the world, please ignore me. Having that rhythm and predictability is really important. And I think, you know, being able to complete something like this in 12 months, I think you're more likely to complete it than if it was spread out over a longer time. So that's our logic. Yeah, so there was your question in there on mentoring. So yeah, when it comes to the MSc, yeah, you're given an individual supervisor. You'll meet with that supervisor. There's about 12 to 15 hours of supervision. And again, it goes in peaks and troughs. When you're designing what your research project is, it's a pretty intense period of supervision while you're working out exactly what your project will be. Then while you're actually doing it, it tends to be a little less. And then in the lead up to submission and putting together the conference poster and the journal article, again, the drafts of that, you know, there's a lot of feedback at that point. So yeah, it's a very supported process for those of you that go on to the MSc part.
I think that's it, guys. We've gone over the 1 hour mark. So what I will say is, once again, you will receive an email with the recording of this webinar, and you will receive a link to progress your application and to pay your deposit. And you will receive a call from our education advisors who will phone you and just see if you have any other queries and if you want to progress to application. And they will be in touch with you early next week.
Brilliant.
Sarah, could you stay on with me a minute? I want to chat to you, Sarah. Would that be all right?
No problem. Yeah, fine.
Oh, is Colin host? Because we have to make you host or it'll be shut off. I'll make you host, Colin.
Are you going to cut off?